That's the X-ray before and after. We have a direct linear advancement, the upper and lower jaw forward, and his symptoms are all gone. But obviously, because we bring the upper jaw forward, you can see his nose tip will tip up. And from the frontal view, his nose elevates, got wider, even though there is a surgical technique to try to minimize the elevates with this. The elevations, but you see the facial change. And this is another patient. She is a class 2, very retronatic. And after the MMA, she has much more balanced face than before. So retronatic is corrected. And you see the similar kind of side effect. For this case, actually it worked favorable for us. Her nose is slightly wider and her nostril also get wider. So because we bring the upper and lower jaw forward, you're going to increase the anterior posterior dimension. And also, as you see, this is before MMA and that's after MMA. You never really trust airway images from the cone beam, but this is just an example. And also the transverse dimension increase. Not just bring the upper and lower jaw forward, AP dimension increase, you actually increase transverse dimension as well. And last decade so, our surgeon focused more on the counterclockwise rotations. You probably have heard about the counterclockwise rotation. Why counterclockwise rotation? Because you like to flatten the occlusal plane, and you don't need to bring the upper jaw forward a lot. Most of the anesthetic side effect is related to maxillary advancement. So when they flatten the occlusal plane by counterclockwise rotation, you don't need to bring the upper jaw forward a lot. You can still bring the lower jaw forward. So the counterclockwise rotation to minimize the potential negative aesthetic effect of the maxillary advancement and also to maximize the mandibular advancement. So the most of the patients now doing the surgery, they have some form of counterclockwise rotations. So a couple of years ago, we did a study because you cannot really operate the three different surgical procedure for the same patients. So we have a fresh cadaver head, and we simulate the three different surgeries. So one is a linear advancement like old-fashioned. Another second one is a 5-degree counterclockwise rotation. And then third surgery was a clockwise rotation. So it was a fresh cadaver head. We did operate the surgery, and we brought the tongue forward. We hooked up the CPAP machine to blow the air, trying to open up the airway, and we did the imaging and measured this computational fluid dynamics, trying to understand how the airway dynamics change. So airway volume increase, the counterclockwise rotation is the most. And also all the other computational fluid dynamics measure, pressure drop, airway resistance, and airway velocity all show counterclockwise rotation is the best. And let's look at this patient. This patient is a 15 years old juvenile rheumatoid arthritis, very retronatic, and you see her, basically she doesn't have a lower jaw. Very retronatic. And this is her MRI images for her TMJ. And even with the extraction, she has a pretty big open bite and large overjet. And she had a total joint replacement surgery as well. And this is her face. So you can see before and after is a dramatic change over aesthetics. At the same time, her sleep apnea was improved. There's a small pictures and then profile pictures. So these types of surgery can be life-changing procedure. This is another patient. Patient is 43 years old, but he looks much older than 43. He looks almost like 60. But AHI, which is apnea-hypopnea index, over 30 considered severe. His number is 67. 67 means he stopped breathing more than 10 seconds, 67 times per hour. So you can imagine how tired he's going to be. He's continuously waking up at nighttime, and he was a truck driver. So he had a many car accident, and he came to us not just to improve his profile, he wants to actually fix the problem because he doesn't want to die. And he had multiple procedures from the ENT, UPP, uvulopalatal They cut out the soft palatal out, but it did not work. So he had many orthodontic problems. He got root remnants and macrodontia, and we set it up for the surgery. So we did counterclockwise rotation, bring the upper jaw forward, and then lower jaw forward. And that's the after the surgery. And he has much more balance, and his body looks good. And this is after the surgery. And before cone beam and after the cone beam, you see how much of the lower jaw advancement we did. From the other side, we have counterclockwise rotation. We brought the lower jaw and upper jaw forward. So many of these maxillary advancement or MMA cases, a lot of time they need some kind of maxillary expansion. So this is a pre, post, and 1 year retention. His AHI, apnea-hypopnea index number was from 67 to 2. So totally normalized sleep apnea. So we applied this new technique called the fluid structural interaction. This is not a regular CFD. It gives the airway tubes a compliance. Very complicated calculation, but at least we can see before we're doing the actual real drug-induced sleep endoscopy, we can see where is the potential obstruction site. And then this is another after the surgery. So we prove MMA worked really well for these patients. So let's look at this another patient. Patient has class 2, she has a lip incontinence, a little bit of long face, and a little bit of retruded the upper jaw and then lower jaw. And we did the MMA, but at the same time we have to do the 3-piece maxillary expansion surgery. So that's the after the surgery. We did before and after. And her face is much more balanced. And her sleep apnea was fixed. But previous 2 speakers, I talked about the maxillary expansions. So there are a lot of ways you can do the maxillary expansion. But I'm talking about the surgical expansion. Because we have a suture, or a surgeon can cut the upper jaw, they can expand the upper jaw. And there are 2 different ways. Traditional one would be the SARP, which is a surgical assisted RPE. Another one is segmental expansion. We call the 3-piece maxillary expansion. So these are the very common. But what about the mandible? You can expand a lot for the upper jaw, but what about the mandible? Are you going to leave the posterior buccal crossbite? If you expand 10, 12 millimeter upper jaw, that's the problem. So the limiting factor is the mandible. There's some appliances you can try to expand the mandible, which is probably not a good idea. Maybe for the mixed dentition cases, you can use these types of appliances for the expansion. But many studies, they already show stability for the transverse expansion, especially for the mandibular arch. When you look at it, if you expand, let's look at the intercanine length. If you expand the lower intercanine length more than 2 millimeters, you put a fixed retainer, most likely they will stay, only 0.3 millimeter relapse. But if you expand 1.15 millimeter intercanine width, if you have a removable retainer, then they almost all the way collapse right back. So this is proven many studies. So many studies, they said intercanine width decreased for pre-treatment value. So even though you do the surgical assisted RPE for the expansion for the upper jaw, you try to expand the lower jaw with orthodontic only, most likely they're going to all collapse back. So intercanine width should not be increased orthodontically. This is the bottom line. Did we all learn from our orthodontic residency program? Because of the mandibular arch form dictates the upper arch form, and challenge remains to increase the mandibular width to accommodate the maxillary expansion. So this is one of the challenges we have. Since we don't have the suture for the lower jaw, how are you going to expand the lower jaw? Then you have to surgically create the suture. You split the lower jaw and then gradually expand the lower jaw. That we call the mandibular midline distraction osteogenesis. Or you call the mandibular symphysial distraction osteogenesis. It was very popular probably in 1990s and 2000. There's some side effect and all disappeared. Now it's coming back. So we call the MMDO, mandibular midline distraction osteogenesis, a surgical technique to widen the mandible by slightly expand the lower jaw. Okay? So let's look at this case. This is a 59 years old. His AHI is a 44.8. He looks much older than his age because of the sleep apnea. He could not sleep really well. And when you see his overjet, he has probably 10-12 millimeter overjet, pretty big class 2, and upper arch is very narrow, and the lower arch also very narrow. So this is his bite. So you can do all kinds of expansion for the upper jaw. What are you going to do about the lower jaw? Can I expand, putting the wider arch form to the lower arch to expand? Yes, we can, but most likely it's going to collapse right back. So our treatment plan was surgical assisted RPE. So we have a surgical assisted RPE, and then this is the procedure we call mandibular midline distraction osteogenesis. It's I would not say the pretty simple procedure, but the operation time probably is less than 30 minutes. So you cut it, and then you split from the bottom, and then go all the way up, but you have to leave the soft tissue intact from the lingual side for the blood supply. Okay? And we use these types of hybrid expander. Two arms will go around the canine or bicuspid, and two arms will go to the bone. And then jack screw part will be exposed outside. And then you turn that screw, and that's after the surgical assisted RPE we finished, and that's the lower, after we finish the lower jaw expansion. The reason why we have a braces with the stainless figure 8 tie is we don't want this teeth migrating into the spaces we just created. So we put the braces on and get in line. Is now ready for the second surgery, which is MMA. And this is after the MMA. So you can see the arch form totally changed before and after. He has a nice class 1 occlusion, and you don't see much of the lower incisor gingival recession. And that's the before and after. And his profile obviously changed. When you compare the arch form change from the lower arch especially, we expand, and that means we don't need to procline the lower incisor as much. So how the surgeon cut? Ideally, they have to cut right in the midline. So that would be ideal. However, sometimes there's a lot of crowding, you don't have a space to split it. And in that case, surgeon can go around. They call the perimedial osteotomy. Ideally, midline osteotomy. So when they plan, when surgeon cut the lower jaw, they usually don't cut all the way up. You have to look at the root, and usually around the apex area or maybe 1/3 over to the root, and then they stop and they use a chisel and hammer to split in between. But the delicate part is when they split the lower jaw, they have to have both sides of the alveolar bone. If some reason they had a bad split, one side of the lower incisor root is totally exposed, then patients can lose a lower incisor. That's the delicate part. So it's a very technique sensitive procedure. And now we are doing more and more careful. We have to do the pre-distraction orthodontics. I like to make sure you have enough space. So intentionally put the bracket slightly off, trying to put the root out, and also putting the open close spring to create in between the two center incisor. Once you have enough space, then you send out for the surgery. And this is very important because after the surgery, you don't want to expand right away. They have to wait for at least 1 week. We call the latency period. Then you begin 0.25 millimeter per day. Most of the expansion for the upper jaw, CAD-supported RPE, surgical supported RPE, we did for 0.25 up to 1 millimeter, believe it or not. But now we're going slow. About 0.25 and maybe 7 to 11 millimeter expansion. There are 3 different types of expander. One is a tooth-bone, bone-bone hybrid like the upper RPE. So this is a tooth-bone distractor, basically the same like a 4-banded RPE. But problem is the jack screw, if the lower jaw is extremely narrow, you cannot put the place jack screw from the lingual side. That's the problem. Another one we call the Rotterdam midline distractor. This is a bone-bone distractor. And this is the example of the bone-bone. And you see the cone beam. We separate it totally. Third one is a Bologna midline distractor. Hybrid is the appliances. Bottom one will go to the bone. Upper one arm will go around the premolar or the canine. So this is another example of the Rotterdam expander. So when we expand the jack screw about 7 millimeters, usually the incisor open up about 5.1 millimeters, and the intercanine will increase 4.4 millimeters, and first molar increase 3.2 millimeters. It's the same like the RP. You have more expansion in the anterior than the posterior. And there's a review article, and they measure the skeletal expansion versus dental expansion compared with the 3 different types. Basically, the hybrid versus bone-bone, they are very similar, but the tooth-bone appliances, as we expect, you have a little bit more dental expansion than skeletal expansion. So if you need more skeletal expansion, maybe you have to do the hybrid. But if you need more dental expansion, you can do tooth-bone expander. But one of the concern is when you separate, they expand, the TMJ condyle is going to rotate it distally, medially. So if you expand intercanine with 6 millimeter, the condyle will rotate it about 3 degrees. And that can cause a TMJ issue. So you're going to have to screen the TMJ symptoms before we plan for these types of surgery. And one study, and they look at the patients. Most of the patients, they don't have any symptoms. But some patients, they have a transient 4% of the TMJ, or clicking sounds and popping sounds. Only 2% patients have a TMJ. In terms of the complications, some minor complications like ulcer, but some major as a dehiscence, some TMJ, sensory disturbances, failure, but 1%, maybe 2% patient can lose lower incisor. Because surgeons, when they split, somehow they close close to one side, you have totally exposed alveolar bone of the root on one side, then patient can lose a lower incisor. But in terms of which one is better or worse, basically there are not differences. They're all the same. And then another question we have to ask, orthodontic tooth movement during the consolidation period. It's same thing like the marquee. When you expand the marquee, when you're going to start to put the braces on and trying to move those upper incisors, there's some people, they suggest, maybe we should do the early orthodontic movement during consolidations. But also another group actually no, may not be the good idea because you have unstable bone, healing delays, and some risk. So my recommendation is don't move the teeth into the empty space. All the RP patients, when you expand, you don't actually put the braces on and power chain to close the diastema. Usually, they just close by itself. For the lower, I would like to wait at least 8 weeks or maybe 12 weeks and then put the braces on and use a very light wire to just not close the space, just align them, and then once you get to the bigger wire, and then slowly close the space. So let's look at this patient. This patient, he is class 1, or he has a severe sleep apnea. I would like to extract the 2 lower incisor, not the 2 lower incisor, the 2 premolar of the lower bicuspid. But since he's missing teeth, we decide not to extract any teeth. And this is a pen, is F, and we print the lower with the plastic model, and this is the hybrid expander. You pre-bend, adapt it to the lower mandible, and then we do the surgery. And once you put it in, you split the lower jaw, and make sure you have to turn the screw to separate the 2 segments. Once you confirm it, then you dial back and then suture it up. And then this is how much of the expansion we did for the lower jaw. So we did about 10 millimeter expansion for the lower, and that's the cone beam. And a couple of months after we put the braces on and slowly close the space, and then patient is ready for maxillomandibular advancement surgery. So for this patient, we did not need to expand the upper jaw. So upper jaw, we need to bring 6 to 5 millimeter forward. But because patients had a bad TMJ, osteoarthritis condyle, we decided to do the total joint replacement surgery. So I'm going to show you briefly about the surgical procedure. They expose TMJ, and this is articular disc. Then remove it. You can see there is a perforation of the articular disc. And then you cut down the coronoid process of the condyle and putting the artificial fossa. And then putting the joint, and then this is after the surgery. So why we did the lower jaw expansion? Because as we want to bring the upper and lower jaw forward, which other dimension is we did not touch? It's the transverse dimension. So we want to expand the lower jaw and upper jaw at the same time we bring the upper and lower jaw forward, because I don't want this patient to go to the second surgery. So that's before and after. So the lower arch before and after. And at the end, when you measure the canine width, we did not increase 10 millimeter. All the spaces we used to align the lower incisor, we did not procline the lower incisor a lot. And that's before and after the expansion. And that's after we closed all the spaces. So that's his face. His sleep apnea symptoms are almost all gone. And when you look at the lower, especially the lower canine angulation, lower canines are now after the expansion, they are pretty much straight up and down. And this is the before, and that's after the expansion. And even after the expansion, we did not flare the upper canine crown tip out. This is alveolar bone only. And the teeth, it flares slightly, but we did not overly flare out the lower canine and lower incisor. And after the treatment, canine, premolar, and all the way to the molar, they're pretty much straight up and down. That's before and that's after. This is alveolar bone. You see the canine area, we did not increase the dehiscence. That's the teeth angulation. You see the canine, we upright it because we expand the lower jaw. So this type of two-point distractor advantage is pretty cheap because it's same like the RPE. It's a reduced cost, easy installation and removal. You don't need a second surgery. Less gingival impingement, however, problem is speech problem because it's positioned on the lingual side and periodontal problem, you will have some issue. But the bone or hybrid distractor is advantage is no minimum need for dental increase. However, the problem is you have to do the second surgery to remove them. So you have to make the decision which one you would like to use. However, we still don't know about the choice of distractor, surgical setting, distraction rate, start of orthodontic treatment, and relapse. We still have to do a lot of research. So let's look at this patient. This patient is quite interesting because he had a sleep apnea and long face. So we did the upper jaw and lower jaw maxillomandibular advancement. And the AHI number from 30 to totally normalized 0.3. So he was cured by the sleep apnea or just totally normalized. That's his face. He looks a little bit more prognatic, but we did the surgery not just because of we want to improve his face, we would like to fix his sleep apnea. So he looks fine, but about 1 year after, he had to use again for the CPAP, and then all of a sudden, his AHI number increased up to 12. And now he feels some symptoms. And when we look at his tongue, we see the severe indentation of the dentition on his tongue, which means his lower arch is maybe just too small, or his tongue is too wide. Have you guys ever seen the tongue reduction surgery? I've seen only one time during my career. They call it keyhole procedure. You probably don't want to do that. It could have a lot of complications. And patient still feels symptoms, and he doesn't want to feel the symptoms and then falling into sleep apnea. So he wanted to do the surgery again. So since we brought the upper and lower jaw forward, what else we can do? We can bring it forward, but we don't want to bring it too far forward to make it totally bimax protrusion. It's like a horse face or monkey face. Other dimension we did not touch was a transverse dimension. So we decided to do the expansion. So we cut it, and those are the bone distractor. We prevent it, and then fixate. And then you have to make sure when you turn it, those are the separated. Okay? Once you confirm, you dial it back. That's before. That's after we place it. And we have 12 millimeter distraction. We went all the way because I don't want this patient to go to the third surgery. That's a 12 millimeter expansion. And obviously, the cone beam airway image is probably not the best, but when you measure the volume increased double just by expanding only. And then we did another maxillar 3-piece expansion and bring the lower jaw forward. About 10 millimeter advancement in the upper jaw and 6 to 8 millimeter lower jaw advancement. So we totally make it prognatic lower jaw. So that's before surgery, in the middle, first MMA, and then third, after the second MMA with the bimaxillomandibular expansion. So interesting thing was the minimum cross-section area from the 63, and then first MMA, 272, second MMA is a 427. That's his face. We did not make the really bimax. His face is still okay. And then we confirm by using the drug-induced sleep endoscopy and confirm is there any obstruction while he's sleeping, and we confirm there is no obstruction. And then he was happy. So now we are making this a customized distractor. This patient also, she needs an expansion of the upper jaw and the lower jaw. She's a sleep apnea patient. And then we make this a metal printed expander. You have those 6 holes in between the root. You can use a mini screw to secure. So it has a bone anchor, and also because it is cemented over the crown, you will have some dental support as well. These patients, we exposed and we did the cut for the lower jaw. And patient showing some space, about 6 millimeter expansion, and then that's after we finish the lower jaw expansion. And the teeth is actually pushing it out slightly because you are putting the expansion force to the crown area, not to the bone area. So that's about the expansion. We have about 8 millimeter lower jaw expansion. And we put the spring to make sure the lower incisor is not falling into the expansion space. And we move it, and that's before and after the expansion. That's the lower arch before and after the lower jaw expansion. And that's before and after we put the braces on. And that's before, after the surgery. And teeth are kind of falling on the sideway. And we did not increase the recession. They're pretty much the same. The angulation of the teeth, they maintain the same. But eventually, they're uprighted. You see the premolar canine to the premolar all the way back, they're pretty much straight up and down.
Trong khi đó là Việt Nam đang đi theo trường phái đấy, giới trẻ đang đi theo đấy.
And then patients is ready for MMA, maxillomandibular advancement surgery. And then this is after the surgery. So we did not make the bimax protrusion. We did some advancement of the upper with 3-piece maxillary expansion. And that's the after the surgery. And that's the after the surgery. So she has a little bit better profile, and we expand the upper jaw surgically, and we expand the lower jaw by this direction. And that's before and after the surgery, lower arch, and that's the profile before and after the surgery. And this is another patient for the printed expander. And in this case, lower incisor, canine, premolar, they are pretty much straight up and down. See, they stay exactly the same. So this is alveolar bone. Gingival recession to the premolar, canine area did not change much. Root angulation from the canine, premolar, all the way back to the molar stay the same. So this customized structure, what's the advantage? It's a reduced cost, easy installation and removal. You don't need a second surgery to remove. Simply just unscrew the mini screw and then you can remove it. However, disadvantage is still is in the lingual side, tongue irritation, speech problem, and if you not plan well, then mini screw can actually hit the root and you can cause some root damage. But you have to know, by expanding only for the lower jaw, it's not going to cure the sleep apnea. The reason why we propose for the lower expansion is to maximize the maxillary expansion. And symptoms reduce because of the maxillary expansion and then MMA. So the conclusion is, if the MMA is planned and surgical maxillary expansion is necessary, then evaluate the mandibular arch is crucial. When you do just for the upper jaw expansion without expanding the lower, you're going to be limiting. So you have to plan or can I expand the lower jaw? Can I orthodontically expand the lower jaw only? If not, then you may have to do mandibular midline distractional stereotaxis. This will give us a greater maxillary expansion, may enhance the treatment outcomes of maxillomandibular advancement surgery.
Nhiệt nhá.
Thank you so much.
Thank you very much for your wonderful presentation. I'm pretty sure we will have a lot of questions from the audience, but
Hai đứa hai cái.
because we're going to have a little lunch break.